Can you tell what this cartoon diagram is showcasing in the right side of this screen? If so, you're on the right track. Are you thinking coagulation cascade, perhaps? Right. So that is somewhat linked to our main topic of today, which is primary hemostasis pathology. My name's Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. Make sure you have this book, Medical School Pathology and Step 1 Review. It has everything in it that you need to do extremely well on Step 1. I think it's pass-fail nowadays. Now, a little bit lackadaisical people are getting. It's actually showing that more people are failing nowadays than in the past. And I believe that's due to people, thinking that this Step 1 exam is, I'll get to it. I don't need to study as much. It's quite the contrary, and there's higher competition, so make sure you're ahead of the game. We're going to get you there. Primary hemostasis has many steps. Like that 1,000-mile journey, it starts with one, so let's start there as well. A Step 1 part of primary hemostasis, there is transient vasoconstriction of a damaged vessel. A vascular spasm is activated, which leads to vasoconstriction, right? The vessel kind of squeezes down to tamp that flow through it. The vascular spasm is mediated by a neural reflex, as well as contraction of endothelial cells due to endothelin being damaged, released from neighboring endothelial cells that were damaged. Got that? All right. Step 2 for primary hemostasis involves platelet adhesion to the surface of the disrupted vessel. Platelet adhesion takes place as a result of the interaction between various inflammatory mediators released by the extracellular matrix. And one of the main mediators of platelet adhesion, you must know this, is the von Willebrand factor. Remember that? Von Willebrand factor? Von Willebrand factor binds to the GP1B receptor and results in the attachment of the platelet to the damaged vessel. Von Willebrand factor is derived from the Weibel-Palade bodies of endothelial cells, and it's also present within the alpha granules of platelets. Step 3 of primary hemostasis involves platelet degranulation/activation. Adhesion of platelets results in a change of platelet conformation. Platelets release cytoplasmic granules, which contain factors such as ADP and Thromboxane A2. Platelets also undergo a change in shape and become pseudopodal under the influence of P2 gamma 1 receptors. And this leads to the various release of cytokines and chemokines. Step 4 of primary hemostasis is platelet aggregation. As a consequence of platelet aggregation, platelets form an aggregation called a platelet plug. That's the whole point of primary hemostasis, to form a platelet plug. But this platelet plug, it's weak, like you when you go to the gym. Just kidding. But this platelet plug is weak. And this platelet plug needs to be stabilized. And what stabilizes it is the coagulation cascade. The coagulation cascade is part of secondary hemostasis. Secondary hemostasis is to stabilize. In regards to primary hemostasis, you can see right here in the middle, figure 4, this somewhat of a clot that's forming at the esophagus of a patient, right? In the future, you might actually see this in person in the hospital or a clinic somewhere. And you'll know that primary hemostasis is at least occurring because there's this formation of a soft, weak clot. Remember, primary hemostasis forms the platelet plug, right? And secondary hemostasis stabilizes it via the coagulation cascade. That's why these other two images are on this screen. But like many pathologies, we can have problems. So let's talk about some disorders of primary hemostasis. Disorders of primary hemostasis are typically due to abnormalities in the platelets. Now, these disorders of the platelets can be quantitative, right? Quantity, like number. Or qualitative, like quality, like how good is the platelet, right? So the disorders are divided into quantitative platelet disorders and qualitative platelet disorders. Clinical features of primary hemostasis include many things related to abnormalities with primary hemostasis. So you can imagine being in your clinic, seeing a patient walk in with mucosal bleeding, skin bleeding, ecchymoses, petechiae, random bruises, aka hematomas. They smile at you and you notice that their gums are bleeding, prolonged bleeding after minor surgeries. These are all examples of the clinical features that are associated with primary hemostasis issues. With regards to mucosal bleeding, that can present as epistaxis, right? Gingival bleeding, blood in the urine, coughing up blood, hemoptysis, hematemesis, and even menorrhagia. Severe thrombocytopenia may result in intracranial bleeding, right? You might need to call a stroke code. Symptoms of skin bleeding include petechiae, and you remember the sizes from derm, right? Your derm rotations, etc. Petechiae, 1 to 2 millimeters, or ecchymoses, greater than 1 centimeter. Purpura, greater than 3. Check those units. As well as easy bruising. Petechiae are a sign of thrombocytopenia and are not usually seen with qualitative disorders. The image on the right here shows what you will see clinically if your patient has some sort of clotting factor abnormality, such as scattered petechiae or purpura. And I believe purpura is greater than 3 centimeters. Do me a favor and check the units. Let me know. I'll figure out what it is. And the updated, more current, best new version posted on the website will have it there. Disorders of primary hemostasis. Well, you're going to need to be able to measure these, right? You need to measure bleeding time, platelet count, perhaps get a blood smear, a peripheral blood smear. Or you might even need to perform a bone marrow biopsy or have someone perform a bone marrow biopsy, right? Because you need to get information. Bleeding time normally is between 2 to 7 minutes. If it takes longer than that for bleeding time, then there's highly likely an issue. In primary hemostatic disorders, bleeding time is prolonged. Normal platelet count is 150,000 to 450,000 per microliter. You can see abnormal platelet numbers if you get a CBC with diff, or if the pathologist reviews the blood smear under a slide and notes lack of platelets, thrombocytopenia, right? Blood smears are used to assess the number as well as the size and the shape of the platelets, because like we're going to see later on, you can have giant platelets, those big suckers, right, associated with Bernard-Soulier. You can have abnormal platelets, and you can have no platelets, right? So be aware of that. Now, a bone marrow biopsy is used to assess megakaryocytes. What are megakaryocytes? Those are the cells that, upon maturation, get cleaved down, and the platelets are actually formed from their cytoplasmic budding. Megakaryocytes produce platelets. If the bone marrow biopsy doesn't show any megakaryocytes, that might hint at an issue, i.e., why the platelets aren't being produced. Spontaneous bleeding can occur with a platelet count under 10,000 microliters, and surgical bleeding with counts below 50,000 microliters, right? So abnormally low platelet counts can be the precipice for getting a platelet transfusion, right? 1 unit of platelets, 2, 3, etc. Let's talk a bit about immune thrombocytopenia purpura, because this comes up a lot. Immune thrombocytopenia purpura is an autoimmune disorder that's characterized by the formation of IgG antibodies against glycoprotein 2B3A receptors and their destruction. This image to the right shows a peripheral blood film, something that the pathologist would look at, or maybe the hematologist. And notice that there are these big platelets that are there. Those platelets are causing issues. And this is from a patient with immune thrombocytopenia purpura. If you're wondering what those more circular, more abundant cells are, those are red blood cells. And in the top left of this image, that could be some sort of myeloid precursor or an erythroid precursor. Can't quite tell with this image. And it's peripheral blood, so it's probably some leukocyte of some sorts. This image is not a leukocyte. This is a person's skin. And what's wrong with their skin? There's all these little dots on it. These are petechiae. And it looks like he's been picking at it. Scabs. Naughty, needs a Band-Aid. Immune thrombocytopenia purpura is the most common cause of thrombocytopenia in children and adults. So it should be high on your differential when you're walking around the clinic with your little notepad, your paper, you're helping out, you're giving the attending notes, right? They'll smile upon you and think that you're super smart if you have immune thrombocytopenia purpura on your differential when you see skin like this, right? Tuck that one in the back. Immune thrombocytopenia purpura is an isolated thrombocytopenia. Hematocrit and white blood cell count is normal, usually, in immune thrombocytopenia purpura. Autoantibodies are produced by plasma cells. You remember those plasma cells with the perinuclear HOF, the eccentric nuclei that's up against the edge, right? You remember what plasma cells look like, and you know that multiple myeloma has an abundance of plasma cells that are neoplastic, right? You know that. Anyhow, autoantibodies are produced by plasma cells in the spleen. And antibody-bound platelets are consumed by splenic macrophages, resulting in thrombocytopenia. Immune thrombocytopenia purpura is divided into two forms, which are acute and chronic, right? So you have your acute form and your chronic form. This image to the right here shows petechiae on your patient's tongue. This image shows petechiae on your patient's oral mucosa. Acute immune thrombocytopenia purpura arises in children weeks after a viral infection or immunization. So future pediatrics, look out for this. Acute immune thrombocytopenia purpura usually resolves within weeks of presentation, so that's good to know. Chronic immune thrombocytopenia purpura usually arises in adults, and usually those adults are women of childbearing age. This may be primary, like it just happens, not precipitated by another issue, or it may be secondary, related to a condition such as SLE, systemic lupus erythematous. You remember that classic rash associated with SLE? Malar rash, butterfly rash. It's going to come up, I guarantee it. Now, these images show various petechiae involved with, or purpura involved with immune thrombocytopenia purpura. Note that immune thrombocytopenia purpura in a new mother, oh no, that's sad. It may cause short-lived thrombocytopenia in a newborn offspring because the antiplatelet IgG can cross the placenta. Laboratory findings of immune thrombocytopenia purpura include a low platelet count, right, below 50, a normal PT/PTT, normal coagulation factors, and megakaryocytes being present on the bone marrow biopsy. Now, how do you treat immune thrombocytopenia purpura? Well, the initial treatment of immune thrombocytopenia purpura is corticosteroids. Children typically respond well to corticosteroids. Adults may show early response to corticosteroids, but unfortunately they often relapse. IVIG is used to raise the platelet count in symptomatic bleeding, but its effect is short. And in refractory cases, a splenectomy may be performed to eliminate the primary source of antibodies and the site of platelet destruction, right? This is performed in refractory cases. Let's talk a bit about MAHA, Microangiopathic Hemolytic Anemia. Microangiopathic hemolytic anemia is the pathologic formation of platelet microthrombi in small vessels. Now imagine there's little clots forming in the microthrombi in vessel walls, in the small vessel walls, right? Or it's small vessels. You can see why that's a problem, right? Microangiopathic hemolytic anemia means small blood vessels with pathology and hemolytic anemia. Platelets are used in the formation of microthrombi. Red blood cells are sheared as they circumnavigate those tiny vessels when they interact with the microthrombi, resulting in hemolytic anemia with schistocytes. Microangiopathic hemolytic anemia is seen in thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Thrombotic thrombocytopenic purpura, or TTP, is due to decreased ADAM-TS13. ADAM-TS13 is an enzyme that normally cleaves the von Willebrand factor multimers into smaller monomers for eventual degradation. Decreased atom TS13 is usually due to an acquired autoantibody and is most commonly seen in adult females. The large, uncleaved, gigantic von Willebrand factor multimers of TTP lead to an abnormal platelet adhesion that doesn't really work, and that results in the microthrombi formation. Hemolytic Uremic Syndrome is due to endothelial damage by drugs or infection. Hemolytic Uremic Syndrome is classically seen in children with a certain type of microbial infection, usually E. coli 0157H7 dysentery. Now, if they're exposed to undercooked beef, that's a risk factor for this condition. Also, E. coli verotoxin damages endothelial cells, resulting in platelet microthrombi. Now imagine that you're in your clinic. You're sitting there. Come on in, patient, you say after you hear a knock at the door. They come in, they have skin bleeding, mucosal bleeding, a fever. You ran some labs and noted that they have Microangiopathic Hemolytic Anemia. Neurology consult confirms CNS abnormalities. Nephrology consult verifies that they have renal insufficiency. You should have Microangiopathic Hemolytic Anemia on your differential somewhere. Laboratory findings of hemolytic uremic syndrome and TTP include low platelets, right? Thrombocytopenia. Increased bleeding time, right? If your platelets and things aren't working properly, it's highly likely you're going to bleed longer. That's why you have an increased bleeding time. There's a normal PT to PTT ratio because it's not necessarily the coagulation cascade factors that are messed up. Hence, you have normal coagulation cascade and factors. Due to the lysing and shearing of red blood cells, there will likely be anemia present. Schistocytes for that same reason. And the bone marrow should be normal, so the megakaryocytes should be present on the bone marrow biopsy. Treatment of hemolytic uremic syndrome and TTP involves plasmapheresis and corticosteroids, particularly in TTP. And this image here to the right shows a blood smear with RBCs, red blood cells, that have been impacted by that shearing issue. This patient had a disseminated non-small cell carcinoma of the lung. What else is going on here? Note the spherocytes, though. You see the spherocytes, and do you see the RBCs that look like helmet cells? So let's move on to qualitative platelet disorders. Qualitative platelet disorders are due to low quality platelets. In qualitative platelet disorders, the number of platelets are normal, right? This is qualitative, so the number of platelets is normal. The quality is abnormal with qualitative platelet disorders. Therefore, the structure and or function of platelets is low quality. Examples of qualitative platelet disorders that you're definitely going to be asked about are Bernard-Soulier Syndrome and Glanzmann Thrombasthenia. We're going to talk a bit about those. Bernard-Soulier Syndrome is due to a genetic glycoprotein 1b95 complex deficiency. 1b95 complex deficiency. 1B95 complex deficiency for Bernard-Soulier Syndrome. Got it? And that deficiency impairs platelet adhesion because the platelets don't interact with von Willebrand factor properly. A blood smear will show enlarged platelets and thrombocytopenia. Glanzmann Thrombasthenia is another qualitative platelet disorder that shows up a lot. Glanzmann Thrombasthenia is due to genetic GP2B3A deficiency, which impairs platelet aggregation. Aspirin irreversibly inactivates cyclooxygenase. Lack of Thromboxane A2 impairs platelet aggregation. Uremia also disrupts platelet function. Both adhesion and aggregation are impaired. And that wraps up primary hemostasis. I know that was a long one. Make sure you understand the difference between qualitative and quantitative platelet disorders. There's a lot of testable material in this section, right? Remember that primary hemostasis is to form the platelet plug, right? There's a lot here. Make sure you got it down. I believe in you. Your mind's soaking up all the information. You're doing great. You're on the right track. You're using your book. You're using the lectures. You're using your notes. You're using your brain, most importantly. You got this. I'm going to give you a applaud. Keep it up. Keep studying. And I'll see you next time.